Good morning, everyone. Thank you so much for attending this webinar. It is an honor to conduct this webinar for the Ernie Els Center of Excellence. My name is Celine Saulnier. To give you some background on myself, I'm a clinical psychologist by training. I trained at the University of Connecticut, after which I conducted a postdoctoral fellowship and then joined the faculty at the Yale Child Studies Center, working very closely with Dr. Zami Klin and Sarah Sparrow, who really fostered my interest and involvement in adaptive behavior for autism. I spent 9 years at Yale and then relocated here to Atlanta at Emory University and the Marcus Autism Center when Dr. Klin was recruited down here in 2011. So I have to say I'm probably biased, but I think the Ernie Els Center and the Marcus Autism Center are two of the most beautiful centers for children with autism in the nation, if not the world. Because I do receive royalties for a book and a measure that I will be drawing information about today, I do need to disclose that both for the Vineland Adaptive Behavior Scales 3rd edition and for the book Essentials of Autism Spectrum Disorders Evaluation and Assessment that I do receive royalties. So before I get started talking specifically about adaptive behavior, I really want to talk about the comprehensive diagnostic evaluation, of which the assessment of adaptive behavior is a critical component. So when we are conducting an evaluation to determine a diagnosis or do a follow-up evaluation of a child or individual with autism, we are always going to look for a baseline of cognition, the whole profile of strengths and weaknesses, then of adaptive behavior, and then also the diagnostic profile, both the developmental history and then current presentation of the diagnostic symptoms. Then there are other multiple components. A speech-language communication assessment is critical to an evaluation, especially of young children with autism. And then depending on the attention, executive functioning, all of those other behaviors, there could be neuropsych testing, there could be psychological or psychiatric testing. But today, really just going to focus on the cognitive and adaptive behavior. When you hear the term high-functioning autism, for example, every time someone's using that term level of functioning, we're talking about cognition. It's really not about level of autism symptomatology per se. So when we think low functioning, we are thinking someone with autism who also has cognitive impairment or the diagnosis of intellectual disability. And then high-functioning autism is autism without the comorbid intellectual disability. And then we have everything in between, every level of functioning. What happens is when you have cognitive impairment, that individual is also prone to medical complications, seizure disorders in maybe 20% of individuals with autism, genetic disorders that are associated with autism that come with their own medical complications, cardiac defects, etc. And then on the flip side, when you don't have cognitive impairment, the individual is more likely to have insight and awareness into their disability, and when that happens, they're more prone to comorbid psychiatric conditions like anxiety and depression. So anytime we're conducting an evaluation or even just treating an individual on the spectrum, we want to take all of this into consideration first and foremost. So we have to define what intellectual disability is. And we use the Diagnostic and Statistical Manual, which is in its 5th edition from the American Psychiatric Association. So intellectual disability has 3 components to meet criteria for the disability. The deficits in cognitive functioning based on a standardized cognitive assessment. Those measures, there are many, many measures of cognitive ability. They have an average score of 100 in most cases with a standard deviation or range of 15 points. So the average range would be between a score of 85 and 115. When we think about impairment, we think of someone who falls 2 standard deviations or more below the mean. So a score of 70 on an IQ test or lower. In addition to having that criterion, there also has to be deficits in adaptive functioning, and we'll talk about the difference between cognition and adaptive functioning in a minute. But adaptive functioning areas are usually in the areas of communication, daily living skills, socialization skills, and independent living. And then the third criterion is that these issues have to have developed in the developmental period. So someone, for example, that is in a car accident, has traumatic brain injury and meets the first two criteria, that's not necessarily intellectual disability. It would be traumatic brain injury, for example. So there are levels that the DSM defines for the severity of intellectual disability: mild, moderate, severe, and profound. And this is really how much support the individual needs in life. So this is the normative curve. So like I said, if you can see this little arrow, here's the average of 100, 85 to 115 is considered the average range. And then this percent of the population falls below a standard score of 70, meaning in the impaired range. I just also want to highlight, because this is a curve, that this percent of the population in the upper end of the normative curve is also off the norm. And I think a lot of people forget that, because when we talk about someone who has impaired cognition, they think, oh, they're not like their typical peers because they're impaired, they have intellectual disability. But we also have to remember that the really, really intelligent people are off the charts as well. So they're not like their peers either. So they might actually have some social vulnerabilities with their chronologically same-aged peers that is not an autism spectrum disorder, but might look like one to some people. So that's why a comprehensive evaluation is so important. This is a busy slide, but it really is to make the point that when we look at a profile of cognitive abilities, verbal abilities, visual abilities, motor, attention, concentration, and processing speed, it's the norm in autism to have a scattered profile of strengths and weaknesses, peaks and valleys all over the place, whereas in typically developing individuals, we more or less have evenly well-developed skills. We all have our strengths and our weaknesses, but our profile overall is evenly well-developed. So that's why using one cognitive score often misrepresents an individual with autism, because they might look very impaired, but they might have some areas of strength. So for example, someone with autism and intellectual disability could actually have some nonverbal skills that are in the average range. These scores, the average is a 10 on the subscales of, for example, the Wechsler intelligence scale for children. Then in an individual with autism that does not have cognitive impairment, then you're actually seeing average scores all over the place, with areas of significant deficit that we want to make sure we're identifying and addressing in treatment and intervention programs. So now I want to define the difference between cognition and adaptive functioning. So think of cognition as a repertoire of skills. This is your toolbox. So your toolbox could be completely full and plenty, or it could have some limitations to it. So intellectual disability or no cognitive impairment. Adaptive behavior is how you apply that repertoire of skills to daily life in a functional, meaningful, and independent manner. And so you might have a huge toolbox, but if you don't know how to use that tool independently and functionally in your real life, it really carries no meaning for you. So we really have to measure both of these things, because an intellectual disability without autism, someone's going to have cognitive impairment, so their mental age will fall below their chronological age, but their adaptive ability, their ability to use the repertoire that they have, no matter how limited, is usually on par with their cognition. In autism, even with the same level of cognitive ability, it's very different. That individual, whether or not their IQ is off the charts at 145 or if it's below at 45, the adaptive skills are going to fall substantially lower than even cognition. That people with autism just struggle for whatever reason to apply their repertoire skills in a meaningful manner. So when we conduct an assessment, we really need to be thinking not only about chronological age, but about mental age as well. So we're comparing adaptive behavior to both age and IQ. So when we take into consideration, for example, a 3-year-old, if I do an assessment on a 3-year-old and that 3-year-old is not toilet trained, I'm not going to consider that an adaptive deficit, because I don't expect all 3-year-olds to be toilet trained. However, if I am assessing a 7-year-old who does not have cognitive impairment and they're not toilet trained, then I am going to consider that an adaptive impairment because they have the capacity to be able to toilet independently, but they're not. Now, finally, a 7-year-old who is severely cognitively impaired and functioning like that of a 3-year-old, then again, I'm not going to have the expectation that they would be independently toilet trained. So we always have to take these into consideration. When we assess using measures of adaptive functioning, they are typically on the same normative scale as the IQ test, with a mean or average of 100 and the range, standard deviation, of 15. The most commonly used measure of adaptive functioning is the Vineland Adaptive Behavior Scales. Now, I did disclose that I'm an author on the forthcoming 3rd edition that's being published this week, I believe. But I will tell you the Vineland was being used worldwide, both clinically and for research purposes in the field of autism, way before my involvement. The next measure of adaptive functioning that's used most widely in the majority in school systems is the ABIS, the Adaptive Behavior Assessment System, which the 3rd edition just came out last year. And then the Scales of Independent Behavior Revised is a little more outdated. However, many places might still use the CIBAR. So because the Vineland is considered the gold standard and we have the most research on it, I will be talking about the Vineland more than other measures. So the Vineland comes in 3 different versions. You can conduct the interview with the parent. So the clinician, like myself, is sitting with the parent or caregiver and actually trying to elicit the information from a clinical interview, semi-structured, in order to obtain the information about adaptive behavior. That is the gold standard way of conducting an assessment. However, not every clinical place or school system or research environment can conduct the interview. So there is a parent-caregiver form where you are actually just giving it as a rating scale. You hand the form to the parent and they fill it out. And then there's a teacher form as well. The domains of functioning in a range from birth to 90 years of age are communication skills. So this is functional, receptive, and expressive language. Receptive is what an individual understands. Expressive is the way an individual uses their language, either through speech or augmentative devices. And then written is your knowledge of letters, numbers, reading, writing. Daily living skills. These are your functional daily skills: dressing yourself, toileting, eating, bathing. Domestic abilities: how well you clean up after yourself. Can you cook? Can you clean? Community rules and regulations. Can you follow community rules? How do you function in the community? Can you take public transportation or drive? Socialization skills, so functional interpersonal skills, functional play and leisure skills, how you conduct yourself with your own time. And then coping skills, behavioral and emotional regulation. And then the motor domain, fine and gross motor skills. Fine motor skills are using your small movements with your hands and fingers. And then gross motor is more of full body, running, jumping, balance. There's also a maladaptive behavior index on the Vineland that is assessing for aberrant behaviors that aren't functional. So this is an optional measure on the Vineland, but it can be very meaningful when given. So based on the research, what we know, as I had already mentioned, in autism, we would expect to see adaptive skills falling substantially below both age and IQ. More recent research is showing that this profile is really more for the individuals with autism who do not have cognitive impairment. And when we do just look at individuals on the spectrum who also have cognitive impairment, we are seeing a different profile, that their adaptive skills might be actually higher than their cognitive ability. And we can talk about this when we get to intervention, because I think when we assess someone with substantial cognitive delays, we're more likely to make recommendations for adaptive behavior. We really need to teach this individual to dress themselves, to be able to toilet independently, to be able to feed themselves. we're not as intuitively likely to do that for someone who has an above average IQ, for example, that we forget that because they have an above average IQ, we assume they can do those skills because of their cognition, when in reality they cannot. The gap between cognition and adaptive functioning, especially in the high IQ group, appears to widen with age. And this is very concerning, because the wider that gap, the more the individual is going to struggle in life. And when we think about adults with autism who need to be independent, the majority of people with autism no longer have cognitive impairment, and yet they're not reaching levels of independence in adulthood, which is of great concern. So to show you some of the research that my colleagues and I have conducted, over here on the left, Ami Klin and I, we looked at a sample of high-functioning boys with autism between the ages of 8 and 18, and the dotted line is their average IQ, roughly right around 100, solidly average, and then the colored bars are the scores on the Vineland. Adaptive communication in red, socialization in green, daily living skills in blue, and the overall composite score in pink. This gap to us was so concerning for a quote-unquote high-functioning group of boys that we contacted our colleagues at the University of Michigan, who was Kathy Lord at the time, and we asked to analyze her data, and we got the same pattern. So this gap that you're seeing here is the greatest between IQ and functional socialization skills. So this is the crux of the disability, that the individuals might have great cognition, but they are unable to apply that repertoire of skills to their functional interactive abilities. And this gap was wider in the older versus the younger individuals. The Simon Simplex collection is a very large multi-site grant that was conducted over the course of 7 years and funded by the Simons Foundation in New York. And more than 3,000 families were collected over the course of the grant, which is the largest network grant that was ever conducted in autism. It rigorously characterized. These individuals had top-of-the-line assessments. So we replicated these findings with over 1,000 individuals with autism, where you're seeing that their IQ, the older and younger individuals, are not differing just in IQ, but they certainly are differing in their adaptive behavior in relation to IQ, meaning that that gap was wider in the older versus younger individuals. Now, because those studies were both cohort studies, they were not the same individuals who were on the younger side versus the older side. We do need to look at this longitudinally in the same sample of individuals to see, does this gap truly widen with age? So when I was at Yale, my colleagues Kasia Havarska and Ami Klin, we had a study where there was an initial evaluation at age 2 where toddlers were given that first diagnosis of autism. They were followed up at 4 to confirm the diagnosis of autism, and then a subsequent grant was awarded that followed these children up at the age of 8. So the dotted red line here is IQ over time. And so you can see that at age 2, at a score of 70, the developmental profile of these individuals was actually impaired. But you can see by age 4, they were obtaining developmental or IQ scores in the average range, which is actually fantastic. This means that early intervention is likely making a difference. When we identify delays in development and we address them in intervention, we can see an increase like that. Now, and that even continued to increase by age 8. However, these lines denote the adaptive behavior scores. It's not surprising that adaptive communication would increase when these individuals with autism were identified with significant language impairments. So they were probably hovering around acquiring the same amount of skills functionally as they were for their development. But their socialization and daily living skills, that gap is definitely widening with age. That was for, I should have mentioned this one right here, this was for the individuals with autism at age 8 that had an IQ in the average range, above the standard score of 70. So when we are looking at those individuals at age 8 who actually did have cognitive impairment, this is their cognition at flat lines, which is what you see in intellectual disability, that the adaptive scores rather, are actually above their cognition. One of the surprising findings that we had in the initial study of those boys at Yale was that we used the gold standard ADOS, the Autism Diagnostic Observation Schedule, which is considered the gold standard in the field for diagnostic assessment. This is a measure that is really assessing the autism symptomatology, the restricted and repetitive behaviors, the social difficulties, the communication difficulties. So we would intuitively think that there is a strong correlation between adaptive functioning and autism symptomatology. So for example, we would think those with more severe autism symptomatology would have more impaired adaptive functioning, and vice versa. However, when we looked at the scores of the Vineland and the ADOS, there was virtually no correlation, meaning that these two constructs, if you will, really had little to do with one another. That regardless of symptomatology, these individuals with autism were very impaired. We do see stronger correlations in younger children, but we were looking at an older sample of individuals. My colleague Pam Ventola and I, we also looked at the individual items within the socialization domain on the Vineland to see if that actually shed light on the impairments that we were seeing. And we did this in toddlers with autism. And so when we looked at the toddlers, so around the age of 2 on average, what were their most significant impairments in the socialization domain? And that's these items here. And you can see that these items, these are skills that infants acquire in the first year of life. So we are really seeing deficits that very, very early on, if we can identify them, for example, within the first year of life, maybe we can close that gap earlier. So as I said, adult outcome in autism spectrum disorders is still pretty grim at this point. And I would say because we have very little research in that area and probably even less intervention for our adults on the spectrum. And there are, as you know, more adults in the world than there are children. So we know that the percentage of intellectual disability is decreasing. Every time the Centers for Disease Control come out with a new epidemiological study, we are seeing that percentage lower. Maybe 20 years ago, the majority of people on the autism spectrum also had cognitive impairment, 70 to 80%. By 2012, we were looking at maybe 38%, and in 2016, it's down to 32%. So that's the good news, that the majority of people with autism do not have cognitive impairment. The bad news is they're still not reaching levels of independence, and the comorbid symptoms can really become so pronounced into adulthood. For example, even psychiatric conditions, there can be some psychosis, there can be certainly anxiety, and often depression and suicidality. So a lot of the studies looking at good outcome in autism, the best have been done in the UK by Patricia Howland. The definition is fairly similar across studies, where you're defining outcome is as living independently, holding down a job, and having successful social relationships. Now, the definition of successful social relationships will vary and certainly will differ from what we as typically developing adults would define as a successful social relationship. It might not be about intimacy and having lots of friends and companions. It might be more of having one mutual friendship, meaning that not only does the person with autism think the other person is a friend, but the other person considers the person with autism a friend. That's very important. But it might be more like adult parallel play, that they like doing the same things together, but it might not be as interactive as we would intuitively think. So good outcome and very good outcome would be being able to hold down a job, live independently, and have those successful relationships. And then fair, poor, and very poor. So when we look at it that way, you can see that the majority of individuals on the spectrum are not reaching these levels of very good and good outcome. And that's of great concern. This percentage of the pie is increasing, so that's good news, but it's certainly a very small piece of the pie. So what role then does intervention play? We have historically heard that the best predictors of outcome in autism are having no cognitive impairment and functional language by age 5. That's usually the benchmark. If a child has functional language, not just a repertoire of nouns and labels, but actual functional language, then that's a good predictor of good outcome. We are learning with more recent research that it's more than that, that adaptive functioning really plays a significant role in good outcome. And we're seeing this more and more with clinical trials. So risperidone is a newer an antipsychotic drug that Larry Scahill and colleagues in the RUP network, so this was a whole bunch of sites across the United States, that looked at the use of risperidone to decrease not the core symptoms of autism, but significant aggression, tantruming, disruptive behaviors, and self-injury that come with having autism. And they looked at that significantly reduced those behaviors, as did parent management training for the disruptive behaviors. The combination of both had a significant outcome in improving adaptive daily living skills in children with autism. A more recent study on just the use of the parent training across multiple sites. The study just got published, I believe, 2 days ago, so it will be out in print very soon, also by Larry Scahill and colleagues, Karen Bears, that the parent training alone was effective in preschool-age children with behavior problems in reducing not only the behavior problems, but increasing adaptive daily living skills and even adaptive socialization skills. A lot of the early intensive behavioral interventions are also showing that they are effective in increasing adaptive behavior. Early Start Denver model, this is another one that you might have heard of that's commonly used. So this is very, very important here, that we know that we can actually enhance the independence of an individual if we start very early on by addressing adaptive behavior. So as a diagnostician, how do we take the test results from all of these tests, cognition, adaptive behavior, diagnostic tests, speech language tests, all of this, and translate it into meaningful recommendations that can enhance this independence? So this is a busy slide, but this is what a Vineland profile would look like. So remember, on the Vineland, you have adaptive communication, daily living skills, socialization, and motor for young children. So if this is a 9-year-old with an above average IQ, we wouldn't see the motor skills because on the Vineland 2, motor only goes to age 6. So in a high-functioning individual with autism, they have a strong repertoire of language. So though impaired, because an average here is 15, these are not going to be flagged as significantly, and certainly not the written domain. Our high-functioning individuals on the spectrum love letters, numbers, reading, and writing. That will always be a relative strength, no matter what the cognition is in autism. So that is going to inflate your overall communication score on the Vineland. So always look at the individual breakdown of the scores. Daily living skills, this really depends on the person, their environment, their family, their intervention. How much is being done for them? How prompt dependent are they? So we don't want to see prompt dependence. Prompting equals no independence. We want to fade prompting. It's useful at a component of an intervention process, but we always want to fade it out. Self-management is the key here. That's what we want to see ideally. And then in our socialization domain, here's where you're going to see the lowest scores in interpersonal relationships and behavioral regulation. The reason why play and leisure might not come out as low in the socialization domain is because of that and leisure. Leisure is in typical development. It's important to be able to manage your own time independently, that you want to sit and read independently or watch a movie or be by yourself. But that plays to the deficits in autism. So they're getting points for their disability there. So you always want to look at that as well. So writing up a Vineland assessment, when we think about the scores that you just saw, that we want to provide an overall summary of performance on the measure, compare it to both chronological age and IQ, and then provide a description of the strengths and weaknesses. And maybe those strengths, for example, if it's in the written domain, we want to highlight the strength, but also highlight that it might not be that meaningful if their highest adaptive skill is just memorizing words and being able to read them by memorization, that's not as functional as we might think. And then we want to identify the topic areas of intervention, and you can actually take the behavior that was assessed in the Vineland and make it a recommendation right in an IEP. So the person does not toilet independently can be a goal and objective right in the individual education plan. So there aren't too many specific intervention programs or curricula that address adaptive functioning. This is one that I don't have direct experience with myself, but I've heard a lot of positive things about it. The fact that it breaks down all the components of adaptive functioning that are in the diagnostic criteria for intellectual disability and that we know are important for independence and autism, that it seems like a good curriculum to use. We also want to make sure that our individuals on the spectrum are just able to take care of themselves and taking care of their personal needs, and this means everything that has to do with puberty. So I think a lot of times there's so much focus on the impairments in autism, the autism symptoms, the language impairments, the behavior disruption, that things fall by the wayside. And we can't let something like personal hygiene, menstruation, masturbation, sex, intimacy, all of that stuff, being able to protect oneself, all of our women with autism, especially the fact that many of them go undiagnosed because they don't have prototypical symptomatology, that we need to protect them by fueling them with independent skills in these domains. And then we want to make sure behavioral regulation is addressed, because a lot of adaptive behavior has to do with regulating one's own. So what ends up happening is, in the realm of anxiety and depression, for example, a lot of the supports that you would just see in psychology and psychiatry for the general population are actually very beneficial for individuals on the spectrum. You might just have to modify the approach as a clinician to be much more directive and concrete to address the individual with the autism spectrum disorder, but a lot of the same types of interventions are going to be quite effective. And then video modeling is coming up time and again as one of the emerging evidence-based practices in the field. So video modeling can be anything from a commercial product, and there are many commercial products out there, and many of them have no research behind them. That doesn't mean they're not effective, it just means they have not been rigorously researched. Two that are widely used, Model Me Kids. That the Model Me Kids DVDs, you can pick the area that you want to focus on in the individual and just buy that set of videos. It will show children acting in the behavior that's appropriate. It will model out ways to, change behavior that might not be appropriate. The Social Express actually does have some emerging evidence behind it. This was a group of Hollywood animators that did the animation behind the product, so it is very high notch in that regard. There's also a whole social network tied into the Social Express that everyone who subscribes to this has their own social network, kind of like their own Facebook, where the families have a safe environment to interact with one another. And they use a lot of current technology. So, for example, when they're modeling out how to act in a certain situation,
they don't give the correct response or way to successfully navigate the problem. They actually ask the individual, what should you do in this moment? And then they're holding what looks like a little iPhone, and it's their digital monitor, and they can choose what they would do in that situation. And if it's wrong, then it goes through the whole scenario of why that's wrong. And if it's right, then there's a whole host of praise. So it's a really well done curriculum. And then medications. To date, there are no medications that really reduce the autism symptoms. For example, that there's not a drug that is going to make someone more social, not yet, or have, less restricted and repetitive behaviors, for example. We have medications that are very effective for the associated symptoms that come with having a social disability, a cognitive disability, and/or a language disability. So as mentioned, risperidone is now an FDA-approved drug for children with autism to reduce aggression, behavioral disruption, and self-injury. A lot of the ADHD medications can be effective for impulsivity, hyperactivity, and inattention in autism. However, you need to do a good evaluation to make sure that that's actually the true symptomatology. So for example, let's start with inattention. Inattention in ADHD, attention deficit hyperactivity disorder, is an inability to attend. Medications, stimulants, for example, like Ritalin, Adderall, they can be very effective in improving attention. In autism, a child might appear inattentive because they're not responding to social cues in their environment, but their attention itself is actually very focused, if not over-focused or hyper-focused. So all the medication in the world is not going to address the over-focused attention as effective as you would see stimulants impacting inattention. Impulsivity, again, impulsivity in ADHD is the inability for an individual to control their impulses. They think they do, they're just going to act. There's no buffer. And so medications can be very effective in giving that time point to say, okay, I should think this through and then not be so impulsive. In autism, impulsivity is often the result of the social lack of awareness. So a person might impulsively say or do something that comes across extremely inappropriate, not because they're impulsive, but because they have no social buffer. They have no idea, no insight into the fact that they thought something and needed to say it. That, hey, that's a really ugly shirt, or you smell bad today. That's not impulsivity per se, that's a social disability. So we need to accurately assess that before we're ever going to address it with a treatment, medication, or otherwise. We have had many studies that have looked into, for example, the SSRIs, the serotonin reuptake inhibitors, to address things like perseverative behaviors, stereotypical behaviors, because those are effective in obsessive compulsive disorder. But the studies are equivocal at this time. They're really not showing to be as effective as we might have thought. SSRIs, however, are very effective in addressing depression and anxiety that comes along with autism in the same way they'd be effective in just general population depression and anxiety. If there is ever a comorbid condition where lightning strikes twice, an individual has both autism and schizophrenia, or autism and bipolar disorder, then of course the medications for the associated comorbid condition will be needed. Seizure disorders, anything that comes with having intellectual disability, then medications can be helpful there as well. Sleep problems are very common in autism, so a lot of times those medications can be helpful. I do want to emphasize something about maladaptive behaviors. A speech pathologist with whom I worked at Yale for many years used this phrase, and I absolutely love it: behavior equals communication. In autism, we can never ever assume that a maladaptive or disruptive behavior is intentional or willful. It's usually the result of the social disability. That person from very early on, probably in the first 2 years of life, was not taught an alternative functional way to communicate their needs. But they still have those needs, and when the needs aren't met, they're going to scream, hit, yell, throw something to get their needs met because they don't have the words, gestures, eye contact to do so more functionally. So we always have to ask why the child's behaving in some way. We can do functional behavior assessments, applied behavior analysis techniques to address that, so that we can teach the functional communication rather than just decrease the maladaptive behavior. So for our adults, these are the things that we should be thinking about very early on in development and not just as they're exiting the school system. We want to make sure that our individuals know how to self-manage, know how to groom themselves, know how to present themselves in an effective way, know how when they're talking to someone to look them in the eye or that person doesn't think they're interested in what they have to say. Very critical for an interview for a job. Knowing how to present themselves in a positive way, but not coming across as arrogant or too self-focused. Knowing how to not only do the vocation, which many individuals on the spectrum have extraordinary skills and they're very competent at the vocation itself, but they can't navigate those simple interactions at the water cooler, in the restroom, or walking down the hallway. That's often what gets them fired because there's a no tolerance rule. It happens once, that person's fired. So, excuse me, we want to enlist people like job coaches, life coaches, teaching parents and teaching everyone in the community about autism and the supports that are needed so that these individuals can be successful. Jed Baker has this wonderful book and many other wonderful books, this one, Preparing for Life, that is very good for that transitional period between the school system, exiting the school system and going into adulthood. When we're thinking about future planning, again, these are very important things to consider, really challenging discussions to have with families and caregivers, but necessary. So for example, if I have a child who's 10 and I'm identifying significant cognitive impairment, that I know that cognitive impairment is going to sustain itself throughout this individual's life, I will have the discussions about guardianship, eligibility very early on so that that family can plan and be prepared, because who is going to take care of the individual when the parents are no longer around? Do they have a sibling? If so, does that sibling even want the responsibility of caring for their affected sibling? So these are very difficult but very important decisions to have. Knowing about their sense of awareness, sense of belongingness, sense of success is very important for the individual themselves. And then these are all the barriers to future planning. So we really want to make sure we're thinking about these as well. More and more individuals with autism are going to college, yet many of them are dropping out and failing to be successful in college. Again, not because they can't tolerate the academics, but because they might have challenges with the social environment, the level of independence. Think of all of the support that school systems provide to individuals with autism when they provide those supports. And then all of those go away in college. A professor on the first day of a class will hand a syllabus that has the assignments for the next 14 weeks of that class without any other mention or support of how to successfully accomplish those tasks. And so these are things that we have to consider as well. The only way an individual on the spectrum is going to get support in a college environment is if they disclose that they have a disability. They don't have to disclose to everybody, but disclosing to the academic officials that are necessary to provide those supports is very, very important to consider. And then we want to make sure we're paying attention to the strengths of the individual as soon as they're identified. Certainly, circumscribed interests, splinter skills, whatever, however they're defined, they can become all-consuming. And if that's the case, we want to curb them as much as we can. But as much as you can foster a circumscribed interest or a splinter skill into something functional that will actually help that person be successful in life, that's ideal. Stephen Wiltshire was a nonverbal individual with autism in the UK who has exceptional drawing abilities. He can see a skyline once and replicate it as if it's just photographic memory. Now, through his interest, his intervention providers used this interest as a means to teach him language. Even though he was, 7 or 8 or 9, I can't recall, he learned language, but very late. He was able to learn the language through the use of his skill as a reinforcer. And now this, I always love this story, and I'm going to borrow it from my old mentor, Dr. Fred Volkmar at the Yale Child Study Center. He was contacted by a school system that said there was a class-wide, like classroom, like all of the grades, were conducting an assignment on the Battle of Gettysburg. And this individual with Asperger's syndrome at the time would not participate. He had no interest in the Battle of Gettysburg, and he said, that's it, I'm not participating. And the school official said, we don't want him to fail. Can you give us some suggestions on how he can be included in this grade-wide project? And Dr. Volkmar said, yes, there had to be snakes during the Battle of Gettysburg. His circumscribed interest was snakes, and wouldn't you know it, he figured out all the different snakes that were indigenous to all the different battlefields, and he had so much fun gathering that information and even more fun disseminating that information to his peers. So this can be a successful application of a circumscribed interest to intervention. Temple Grandin, an adult with autism, wrote this book, Developing Talents, and she herself would say, give this book to parents upon diagnosis of their young child, because you want to be thinking how you can hone their strengths throughout life so that they're independent. And then we want to make sure that there's family and community support throughout the life of a child. We want to make sure that family has support networks. The first thing that happens when an individual is diagnosed, they lose their friendships, they lose their community support, because people don't understand and they don't know what to do. It's not of any malice, it just happens. We want to make sure that all intervention techniques are generalized from the treatment setting to the home and to the community. We want to make sure we're supporting the other family members. You know how much attention an individual with autism gets? What about their unaffected siblings, who are probably losing out on attention because of that? Support for the community, making sure that the community knows what autism is, what it isn't, and how to support it so that they can support families in their own community. And so there are local and national networks all over. Autism Speaks, the Autism Society of America. So these resources are at the state and national level. They can be very effective for families in many communities. So the take-home message, make sure adaptive behavior is a part of a diagnostic or clinical evaluation for an individual with autism, to understand their profile of weaknesses and how we can use strengths to capitalize on those weaknesses and translate them into functional success. Understand that adaptive delays are the skills that are not translated for functional, meaningful, and independent success, and that early and direct intervention to promote adaptive skill acquisition is critical. So we can't just address the language delay, the cognitive delay, the autism symptomatology. We have to foster the functional use of skills, self-management, self-independence in life. So I want to thank all of my mentors, in particular Sarah Sparrow, who developed the Vineland Adaptive Behavior Scales and was instrumental in defining adaptive behavior in our field. Her husband, Dom Cicchetti, my colleagues Diane Goudreau, Ami Klin, Steve Canny, Pam Ventola, and Kathy Koenig, that all contribute to the information that I just presented. And of course, all the thanks to the many children and families who dedicate themselves to our research, because without their involvement, we wouldn't have this information to disseminate. So I am happy to answer some questions at this time, but I do want to thank you for your time and attention, and I want to thank the Ernie Els Center for Excellence for having me conduct this webinar today. I think you can type questions, and because I'm blind, I have to look really closely to see them.
All right, well, if there are no more questions, feel free at any time. You can email me. My email is Celine, CELINE, Saulnier, SAULNIER, @emory.edu. And thank you again for your time and attention.